Hello, I'm Dr. Linda Ehrlich-Jones, and on behalf of the Center for Rehabilitation Outcomes Research at the Rehabilitation Institute of Chicago, I would like to welcome you to the webinar entitled Fundamentals of Measurement in Rehabilitation for Older Adults. After viewing this webinar, please complete an evaluation of this program. Please take a few minutes to help us to improve our future programs. It is now my pleasure to introduce our speakers. Dr. Al Kozlowski is a postdoctoral fellow at the Rehabilitation Institute of Chicago and Northwestern University's Institute for Healthcare Studies. Dr. Jenny Moore is the clinical practice leader at the Rehabilitation Institute of Chicago and has been instrumental in the development of the Rehabilitation Measures database. In her role, Jenny primarily focuses on assisting clinicians with translating research to clinical practice. We would like to acknowledge the generous contributions of the Retirement Research Foundation through their grant entitled Enhancing Clinicians' Ability to Assess, Monitor, and Appropriately Treat Older Individuals Undergoing Rehabilitation. This funding is supporting the addition of instruments that measure conditions prevalent in older adults, as well as this free webinar. The RRF is also supporting one free webinar for each of the next 2 years on measurement concepts, in addition to a low-cost continuing education course on measurement that will be provided in 2014. For information about these future educational opportunities, please sign up for the Center for Rehabilitation Outcomes Research mailing list. We would also like to acknowledge the National Institute on Disability and Rehabilitation Research for the funding of the Rehabilitation Research Training Center on improving measurement of medical rehabilitation outcomes. Dr. Kozlowski.
Thank you, Linda. Following the webinar, learners will be able to select valid and reliable instruments for specific clinical measurement situations for older adults in rehabilitation, describe the common clinical sources of measurement error and decide what to do about them, interpret measurements from one assessment, change across 2 or more assessments, and for prediction in rehabilitation for older adults, and to discuss elements of validity and reliability relevant to clinical measurement in rehabilitation for older adults. Topics in the webinar include common clinical decisions supported by measurement, selecting valid and reliable instruments, understanding the common clinical sources of measurement error, and interpreting measurements from one assessment, prediction of a future event, and change across 2 or more assessments. We will discuss the concepts of clinical utility, validity, reliability, and interpreting scores in the context of 2 clinical cases. We will start by introducing the case of Frank, a 72-year-old male with Parkinson's disease, to present information on the fundamentals of measurement. And we will follow up with the case of Lucille, a 79-year-old female with cognitive functioning concerns.
Frank, a 72-year-old male with Parkinson's disease of 7 years duration, will be the first case that we discuss. This case will provide an opportunity to demonstrate the selection of instruments for specific clinical situations. Frank has Parkinson's disease, classified as Hoehn-Neuer stage 3, which indicates bilateral Parkinson's symptoms with mild to moderate disability and impaired postural reflexes. This stage also indicates that Frank is currently still physically independent, but demonstrating increased severity of impairments. Frank lives independently with his wife, who is 70 years old. Because of health concerns, his wife is unable to physically assist him with mobility. Frank is being assessed in a Parkinson's clinic for potential admission into inpatient rehabilitation. His chief complaint is that he is experiencing frequent falls while standing and ambulating. He also reports decreased mobility, gait instability, and greater dependence in ADLs and IADLs. Frank's primary goal is to reduce his fall risk. His secondary goals are to increase independence and mobility in ADLs. The PD clinic in which Frank is being assessed includes a 60-minute evaluation. At the end of the evaluation, a determination of whether rehabilitation is appropriate must be made. If it is appropriate, the level of care must be recommended by the evaluating therapist. The clinicians would like to investigate various instruments that could assist them with decision-making, and they plan to implement them into routine practice. Since Frank's case is similar to many of the cases they see, the clinicians are evaluating instruments specifically for Frank, but think the selected instruments may be appropriate for many of the patients that they assess. For the purposes of this presentation, we are going to focus on the psychometrics, clinical utility, and indices of change of the instruments instead of the details about the actual content of the instruments.
Measurement and rehabilitation provides a means of understanding important differences within and between our patients in order to facilitate clinical decisions to help them improve or retain the ability to function in their lives. We can organize our clinical decisions that depend on measurement into three broad categories. First, we discriminate between states or levels of function at a point in time. We do this in our initial assessment to determine eligibility for services, to rule in or rule out competing underlying problems, to ensure safety, and to establish a baseline for future change. Second, we measure to plan in part by predicting the risk of future events, such as the falls risk for an elderly patient over the next 3 or 6 month period. And third, we measure to evaluate our treatment outcomes, which requires measuring change in important aspects of functioning through our interventions. Through these processes, we plan our intervention and discharge and provide valuable information to our patients, their families, and members of the care team and others.
From Frank's history, we expect to find deficits in balance, gait, or both, and we want to be able to monitor change over time. If our rehabilitation interventions are successful, we expect to see improvements in balance, gait, or both over a few months. Over the long term, we also want to be able to monitor for deterioration given the natural course of Parkinson's disease. We also know that balance deficits have been associated with risk of falling. Since a fall-related injury could complicate Frank's ability to maintain independence, our first concern is determining Frank's fall risk. For the purposes of this webinar, we are going to focus the instrument selection around static and dynamic balance, since reduction of falls is the most critical concern at this point. It is also Frank's primary goal.
Now that we have some information about Frank and decided that balance is the most important functioning construct for us to measure, we can use an existing database to help find and select our measurement instruments. The Rehabilitation Measures database, which you can find at www.rehabmeasures.org. In our search for balance tests, we select under Area of Assessment, Balance Non-Vestibular. Under Diagnosis, we select Parkinson's disease. Under Length of Test, we select No Preference. And under Cost, we select Free. The search results in 5 balance tests: the Berg Balance Test, the Dynamic Gait Index, the Timed Up and Go, the Activity-Specific Balance Confidence Scale, and the Functional Reach Test. We wonder which of these 5 instruments will be best for us to use to measure Frank's balance. Although we want to use an instrument that is valid and reliable, we require an instrument that is feasible to administer under the constraints of our practice setting. Common elements of clinical utility include cost, time to administer, which can also be described as burden to the clinician and to the patient, the equipment and environmental resources required, and any organizational policies, practices, or procedures that could help or hinder measurement. The clinical record management system provides an example of an organizational factor. A pair-based system might permit flexibility in selecting instruments, but increase the administrative burden to the clinician. On the other hand, an electronic medical record might reduce the burden by streamlining data entry, but constrain the clinician to select an instrument that has been included in the system. Administrative burden is also related to the type of instrument used. Patient-rated instruments are questionnaires that can be administered with little or no burden on the clinician. whereas clinician-rated instruments require the clinician to administer, score, and interpret the measurement.
In Frank's case, we need to find an instrument that will allow us to assess current fall risk, track changes in balance over time, and assess areas that balance is reportedly deficient. Listed within this table are elements of clinical utility for the 5 instruments that were produced in our rehabilitation measures search. Of the instruments listed, the Berg Balance Scale is the only instrument that assesses both static and dynamic balance. This is important to note since Frank reported his falls occur while both standing and walking. Additionally, all of the instruments are clinician-rated with the exception of the Activity-Specific Balance Confidence Scale, which is a patient-reported outcome measure. There are benefits to using both patient-reported and clinician-rated instruments, as one provides the patient's perception of improvement and the other may capture actual changes in performance. Research comparing the two indicates that utilization of both would result in the most comprehensive assessment approach that measures different aspects of balance impairments. All of the instruments can be administered in less than 20 minutes and are free, so it appears they would fit well into this clinical setting. The clinical bottom line for clinical utility includes more than just ensuring that cost, length, and time required are suitable for specific clinical situations. It is also important that the instrument being utilized matches the most important clinical question being asked by the patient and the clinician. Consider the organizational barriers and facilitators, such as the ability for the medical record to support tracking of measurements over time and selection of a variety of instruments. Also consider the support that may be provided by the leadership of the organization to spend portions of clinical time doing follow-up assessments. It is also important to note that every clinic has a different situation from an organizational and process perspective. Instruments that seem to fit in one setting may not fit well into another because of the clinic's budget, barriers, time constraints, or current processes. If an instrument is selected to use in multiple settings within one organization, it is important to include stakeholders from each of the settings in the decision so that these differences can be discussed.
Now that we have considered clinical utility, we will examine reliability. Reliability in clinical measurement is about consistently using instruments with precision. However, instruments we use often function differently under different circumstances and are less precise in clinical settings than in research settings in which they were developed due to greater variation in our patients. Clinicians constitute a critical part of the clinician-rated instrument, so we want instruments with research studies that resemble our patients and setting. And when we administer the instruments, we need to follow the research protocol as closely as possible. Depending on the instrument and how we use it, we may have to consider up to 4 types of reliability. Multi-item instruments, like most patient-reported questionnaires and some clinician-rated instruments like the Berg Balance Scale, condense a series of item scores into a summary score. Adding scores like this makes sense if the items measure aspects of the same construct. Internal consistency provides an indication of how similar the items are to one another, and is often reported with a coefficient called alpha that ranges between 0 and 1, where values between 0.7 and 0.9 are considered acceptable. Intra- and inter-rater reliability provide an indication of how consistently raters can score the subjects on the instrument, and are important for clinician-rated instruments. Rater reliability is typically reported with intra-class correlation coefficients, or ICCs, which range between 0 and 1, or with other correlation coefficients that range between -1 and +1. In controlled settings of research studies that generate reliability coefficients, an ICC of 0.8 might be considered reliable, but clinical practice is far more variable. So the ICC represents the best level that clinicians can possibly expect in practice settings if they adhere closely to the protocol of the instrument. Consequently, we need to look for instruments that have higher coefficients, ideally in the 0.9 or greater range. Test-retest reliability is important for evaluating change over time and provides an indication of how consistently scores can be repeated for patients who are not changing. Note that test-retest reliability is established similar to intra-rater reliability. So again, we look for instruments with higher coefficients. A test-retest ICC has no unit of measure, but it can be used to estimate a margin of error for a score in the same units of the scale. This margin of error is called the standard error of measurement, or SEM.
In Frank's situation, it is very important to find a highly reliable instrument. Since Frank is being assessed in a clinic for inpatient admission, it is likely that this score will be the baseline score for many additional testing periods. It is also likely that different therapists will be conducting the tests, and the variability within clinical practice is much higher than the variability in research. As Al mentioned, we are looking for reliability coefficients that are higher than 0.9 because this is what it would be at best in a clinical situation if the clinicians were as rigorous as researchers with standardization. This table includes both elderly and Parkinson's disease because Frank could potentially be similar to patients studied in both types of studies. Since Frank has been classified as a honing error stage 3, he is beginning to demonstrate bilateral impairments, but is still mostly independent. It is important to review the samples studied in the article's reference to determine the honing error stages included in the PD studies and the impairment level of the patients in the elderly studies. The reliability coefficient listed within this table indicate that most of these instruments demonstrated very high reliability. However, the functional reach test demonstrated poor reliability, 0.64 for inter-rater reliability and 0.74 for intra-rater reliability in Parkinson's disease. The sample included in this study was very similar to Frank, with honing error stages 1 to 3 and a mean of 6.5 years duration. Because of these findings, it is best to eliminate this instrument. Based on the data available, it also appears that the intra-rater reliability for the Berg Balance Scale in Parkinson's disease has not been assessed. Missing psychometric data for specific populations is a common finding. In Frank's case, we would then look to the elderly data, which indicates excellent reliability of 0.98. The sample of elderly individuals included in the cited study, published by Berg in 1989, included patients with varying diagnoses. The mean age of the population was 73, and 28% of them had Parkinson's disease. Given these sample characteristics, we feel that it is close enough to consider for intra-rater reliability in Frank's case. Another consideration for Frank's case is timing of test administration. According to one study, including the timed up and go, reliability varied upon whether testing was performed while on or off medications. Since Frank is likely taking these types of medications, it is important to keep testing conditions consistent, which includes medication cycles. So based on these results, we are going to eliminate the functional reach test from the list of instruments being considered and continue to review the other 4. To summarize the clinical bottom line for reliability, there are a few important points to remember. When assessing an instrument's reliability, it is critical to remember that the reliability coefficient is derived from a research study in which only a few raters were utilized, and they were likely rigorously trained and testing conditions were kept as similar as possible. In the clinical setting, much more variability exists, and many clinicians may be involved in testing. Therefore, a reliability coefficient of 0.9 in the research is really the best it is likely to be in the clinic. In order to maximize reliability in the clinic, it is critical that a team of clinicians review practice and standardize instruments routinely with each other. Once an instrument is standardized within a group of people, it is still necessary to re-standardize regularly, as people tend to drift from standard administration of one instrument over time. Look for instruments with a reliability of greater than 0.9 and internal consistency of greater than 0.7 on patients similar to those seen in your clinical setting. For internal consistency, scores greater than 0.9 may indicate that the instrument has some redundancy within it. Given the time limitations that exist in a clinical setting, minimizing redundancy is of utmost importance.
Having examined reliability, we consider elements of validity that are relevant to the rehabilitation for older adults. In clinical practice, we can distill this abstract concept to finding the right instrument for the situation. In any clinical situation, we want an instrument that can measure the construct of interest for a specific patient or group of patients in your clinical setting under a known set of circumstances and within a valid scale range in order to provide information useful to support clinical decisions. Different types of validation studies relate to our clinical decision categories. Cross-sectional validation relates to ability to discriminate at a point in time. Predictive validation relates scores at one time to the occurrence of a future event. Longitudinal validation provides evidence of the instrument's ability to measure change over time and is typically assessed in one of two ways. First, studies of subjects who remain stable on the construct over time. This method is used to assess test-retest reliability. And second, studies of subjects who change over time. This method is used to evaluate effectiveness of intervention studies. Validation coefficients are usually correlations. When interpreting, look for high correlations on comparable instruments for the construct of interest, low correlations with instruments that measure different constructs, and moderate correlations with instruments that measure related constructs.
To determine a valid instrument for Frank, it is important to consider many different aspects of the case. Frank reported that he frequently experienced falls while standing and walking, therefore the instrument should demonstrate high validity for both static and dynamic aspects of balance. Frank is also 72 and has a Honig-Yar scale stage of 3, which are characteristics that should be similar to the samples studied. Considering that Frank is being assessed for potential admission to inpatient rehabilitation, it is important to consider an instrument that has demonstrated validity in this setting, has the ability to predict fall risk, and can track change over time. Department policies, including support for repeated administration of an instrument, can also impact the validity for the setting. Examining the validity coefficient for the remaining 4 instruments can provide some insight into the actual aspects of balance that they measure. Ideally, a validity coefficient should be greater than 0.6 for instruments that measure similar constructs. The instruments listed on this table include instruments that assess gait, static balance, dynamic balance, and fear of falling. Reviewing the validity results from the research can provide us with information about which of these constructs each instrument actually measures. This can help us be confident that we are assessing what we want to assess. The Berg Balance Scale appears to have an adequate correlation with the functional reach test, which is a static balance measure. It also has an excellent correlation with the functional gait assessment, which is a dynamic balance measure. Excellent correlations are also demonstrated with fear of falling measures. An excellent correlation is demonstrated with the BEST test, which assesses various aspects of balance deficits. Given this data, it appears the Berg Balance Scale assesses both static and dynamic balance in the PD population. The ABC has an excellent correlation with the Berg Balance Scale in PD. Additionally, it has an excellent correlation with the fear of falling measure in a similar elderly population. This indicates that it may assess a different aspect of balance than static or dynamic balance. However, fear of falling or balance confidence could play a role in Frank's falling. The DGI will be eliminated because it has not been tested in Parkinson's disease, and there are other acceptable measures that could be utilized. The timed up and go will also be eliminated because it doesn't appear well to correlate with both static and dynamic balance measures. The results of the validity comparison indicate that we should continue to review only the Berg Balance Scale since it assesses the 2 areas of interest, static and dynamic balance. The ABC may also be considered because it assesses a different but possibly important aspect of balance related to falls.
Scale range is an important aspect of valid measurement. Ideally, we want scores that will fall within the mid-range of the scale. Scores that fall near the low or high ends of the scale, which are also called the floor and ceiling, may not represent valid measurements for a patient. An observed score that is within the margin of error of the ceiling may represent a true score that is actually above the scale end. We show here the Berg balance scale with a margin of error of plus or minus 3.5 points on an observed score. Consequently, the effective floor for a single score on the scale is at 3.5 points. Any score less than this could represent a level of balance that is below the measurable floor. The effective ceiling is at 52.5 points, and any score greater than this could represent a level of balance that is above the upper end of the scale. We will cover how to estimate the margin of error shortly.
There's limited data on floor and ceiling effects for both the Berg and the ABC in Parkinson's disease. However, you can assess whether your patient is likely to encounter a floor or ceiling effect after your initial assessment. You simply determine whether the initial score is within the margin of error for either test end. If it is, the patient would likely encounter a floor or ceiling effect on the scale. It would be best to select an alternate test if you wish to use the instrument to measure changes over time. To summarize the clinical bottom line for validity, there are a few main points to remember. Ensure that the instrument measures what you think it measures by examining validity coefficient between the instruments with similar or different measurements. Also, ensure that the study sample is similar to your patient and that your patient scores outside the margin of error of each scale end for the instrument.
Now that we have selected the Berg balance scale, we can measure Frank's balance and interpret the scores. But first, we will discuss the concept of measurement error. All measurements have error. There are 4 common sources of error in clinical measurement. All devices have some margin of error. The precision of devices that measure physical attributes, such as tape measures or timing watches, is apparent on the scale itself. Error in instruments like standardized questionnaires may not be as obvious, and may be due to items that are not included in the scale that are important, irrelevant items that are included in the scale, or in the structure of the response options. All patients will contribute error through normal fluctuations of the construct of interest. Body weight, for example, will vary from hour to hour and day to day. Walking speed may vary with level of fatigue, motivation, and other factors from time to time. The environment may also contribute error to measurement. Noise may distract the patient or the clinician. Poor lighting may make reading a scale difficult. And the clinician will always contribute error to clinician-rated instruments by using his or her judgment to assign ratings to patients, and may also contribute error to patient-reported instruments if they calculate scores or otherwise participate in generating a response. Some measurements also have bias, which is systematic variation. For example, if a weight scale is out of calibration by plus 5 pounds, it will overestimate every measurement by 5 pounds. Patients may over-report improvement to satisfy the clinician, or may underreport for a variety of reasons. Patients' memories can change over time when asked to recall events, and clinicians may be subject to social response bias or have other interests that influence their judgment in a particular direction. We consider an observed score to be an estimate at a point in time that has a margin of error within which the true score for a measurement could fall. This range can be described by the standard error of measurement, or SEM, which can be adjusted to provide a greater level of confidence in the range of knowing where a true score might fall. This is the first of 2 equations that we will provide. The standard error of measurement is calculated by multiplying the standard deviation from the baseline mean of a test-retest reliability study times the square root of 1 minus the ICC from that study. You do not need to remember this equation, but there are three key features we would like you to note. First is the relationship of the ICC to the SEM. As the ICC gets smaller, the SEM gets larger. Thus, lower test-retest reliability decreases the precision of measurement by increasing the margin of error. As we mentioned earlier, the research study ICC represents the best level of reliability we can expect to find in clinical practice if we administer the instrument the same way as in the study. Second, the SEM is like a standard deviation. So plus or minus 1 SEM from the observed score gives the margin of error for the true score about 67%. Or 2/3 of the time. We can get more certainty about the range in which a true score falls by multiplying the SEM value with a constant for a higher confidence interval. And third, the SEM is a reliability coefficient that has been converted into the same units of the scale from the unitless ICC. When we spoke earlier about floor and ceiling effects on the Berg balance scale, we used a margin of error of 3.5 points. This value comes from a study cited on the Rehabilitation Measures database by Stefan and Seni in 2008. Their standard error of measurement estimate was plus or minus 1.8 points. If we want a higher level of confidence for the range of the true score, we can multiply the SEM by a constant of 1.96, which increases the margin of error to plus or minus 3.5 points for a 95% confidence interval. Graphically, we can represent the standard error of measurement with error bars above and below the point for the observed score. For an observed score of 46, the true score will fall between 42.5 points and 49.5 points 95% of the time. When interpreting the Berg balance scale, observed scores are whole numbers, but the SEM may have a decimal. This can help us to discriminate one score from another more clearly. In our example, the true score could be 43 or 46 or 48, but it is probably not 42 or 50. You will see SEM values in future slides with a subscript for the confidence interval, which we chose to set at 95%.
Some instruments also have a conditional standard error of measurement that has been published. The conditional standard error of measurement has better precision along the range of the scale. However, it requires greater burden for the rater since it is so much simpler to remember just one number as the SEM. This slide provides an example of a conditional SEM. Donahue and colleagues provided standard error of measurement estimates for different scale ranges of the Berg balance scale scores for elderly individuals. The SEM is smaller at each end of the scale, but larger within the middle. The conditional standard error of measurement for a 95% confidence interval is 3.3 points for scores of 1 to 24, 4.5 points for Berg scores of 25 to 34, 3.5 points for scores of 35 to 44, and 2.0 points for scores of 45 to 56. For simplicity, we will continue to use the SEM plus or minus 3.5 points for a 95% confidence interval for this presentation.
Some instruments have been validated to predict the risk of occurrence of a future event. The Berg balance scale is one such instrument. For prediction, look for cutoff scores, risk ratios, odds ratios, or probabilities associated with the occurrence of the event over a specified time frame. Note that the prediction will be most valid for patients who most closely resemble the subjects from the study sample, So compare your patient's characteristics with those reported in the study when interpreting prediction risk. Also note that the prediction will be based on an observed score, which has a margin of error for the true score.
Continuing with Frank's case, we will quickly determine the ability for the Berg Balance Scale to predict falls. The Berg has a maximum score of 56, which indicates functional balance. Individuals who score less than 45 have a 2.7 times greater risk of encountering 2 or more falls. Another study looked at risk of falling once over 6 months, indicating that a score of less than or equal to 49 would have a 50% chance of falling over 6 months, and a score of less than or equal to 45 would indicate a 75% probability of falling over that same time period. When considering the cutoff for fall risk, it is also important to consider the standard error of measurement. In Parkinson's disease, the standard error of measurement with a 95% confidence interval is 3.5 points. Here is a clinical example of application of this information. If Frank scored a 46 out of 56 on his initial Berg Balance Scale, the true score of the Berg Balance Scale is between 42.5 and 49.5 points. Although the observed score is above the cutoff for fall risk, considering the range of the true score, the patient is more than twice the risk of falling than a non-faller.
When interpreting change over time, a minimal detectable change index, or MDC, provides an estimate of the error between two scores from different assessments of the same person. If you know the standard error of measurement for an instrument with a population similar to your patient, you can calculate the minimal detectable change value. This is the second equation that we will provide for you in the webinar. The MDC for a 95% confidence interval is calculated by multiplying the standard error of measurement for the 95% confidence interval by the square root of 2. Note again that the MDC value can be calculated for different confidence intervals, which we denote with the subscript. MDC values are interpreted as the probability that the difference between two scores represents no change of the construct for the confidence interval. Thus, a change greater than the MDC value probably represents a true change in the construct, in this case 95% of the time. When interpreting change, we also need to revisit the scale range. The floor and ceiling effects for patients, similar to the subjects from the study from Stefan and Seni in 2008, are a little more substantial for change scores than they are for single time point scores. The MDC on a 95% confidence interval is about 5 points. So the floor for measuring future loss is also about 5 points, and the ceiling for measuring future gain is about 51 points. Consequently, you will not be able to measure improvements in balance from a score higher than 51, or measure deterioration in balance from a score of 5 points or lower on the Berg Balance Scale. From our series of scores over 4 time points, we can see a true change from baseline to follow-up time 1. Note that the margin of error for follow-up 1 no longer includes the cutoff score of 45 for a 2.7% greater falls risk over 3 months compared to non-fallers. We also note that there has been a steady trend of improvement from follow-up 1 to follow-up 3, but note that this does not represent a measurable change. And the last 2 observed scores are nearing the ceiling for the Berg Balance Scale. We might be thinking that our intervention to reduce falls risk is done, and we can focus on higher functioning activities.
The MDC can provide important information that can impact clinical decision-making. If a patient doesn't achieve a MDC during 2 consecutive testing sessions, It doesn't mean the patient doesn't have potential to make true change. The length of time that would be considered reasonable to achieve AMDC is unknown. You should look for trends toward achieving AMDC, and actual achievement should occur within a reasonable time frame. One way to determine a reasonable time frame is to examine the intervention studies that have included patients similar to yours and the assessments that you are using. Evaluate how long it took the patients to achieve the MDC in that study, and you could aim to achieve similar results with your interventions over that time period. If progress begins to slow based on the results of your standardized measures, 2 actions could be taken. The first, the patient may be approaching a plateau and discharge should be considered. Secondly, the slowing could indicate that a different dosage of the intervention or a different intervention may be required to achieve the patient's optimal outcomes. If you are unsure of which decision is appropriate for the patient, a trial of a new dosage or intervention may be warranted. A frequently asked question about measurement is when and how often it should occur. Administration of these instruments should occur at multiple time points throughout a patient's episode of care. Because the scores of these measures can provide important information that will impact clinical decision-making, testing should occur at regular intervals. Administering the tests at critical decision points, such as prior to a team meeting, is ideal. There is a trade-off with measuring multiple time points, as there is a greater burden for the clinicians. However, the information that can be gained may substantially impact the patient's care. There are several points to the clinical bottom line for interpretation of scores. Since the reliability coefficient is in the denominator for the SEM and MDC, the poorer the reliability, the larger the margin of error. As we previously discussed, it is very likely that the reliability in the clinic is at best the reliability that was demonstrated in the research. In order to appropriately utilize the SEM and MDC, it is critical that clinicians are standardized in the administration of all instruments. The next point is that the score achieved by the patient on an instrument is the observed score. However, the true score will fall within a range of that score. This range should be the SEM with a 95% confidence interval to minimize the chance of error. Prediction scores should also be interpreted while incorporating this margin of error. The minimal detectable change score, or the MDC, gives you the amount of change needed between 2 time points to be confident that a true change has occurred. Watch for ceiling effects when examining scores over time. Once a patient is within the MDC of the end of the test, that test can no longer measure the change that that patient encounters. Now we are going to put this all together with one final case. Lucille is a 79-year-old female who lives alone in a 2-story home. She was referred for outpatient occupational and speech therapy because of noticeable deficits in executive function. Complaints include increasing forgetfulness as reported by her daughter, frequent errors with bill paying, difficulty preparing meals, and concerns that she is taking her medications incorrectly. Her daughter reports that she is thinking of having the patient move in with her, but she works full-time. She is also considering assisted living if more supervision is needed. The patient's goals are to understand her current deficits and their impact on her function and living situation. Additionally, she would like to improve independence in the above areas. For Lucille, we need an instrument that enables us to establish her current status and understand the extent of the deficits, determine assistance required for daily living, and monitor improvements or decline in cognitive functioning over time. In our search for balance tests, we select cognition for area of assessment, geriatrics for diagnosis, no preference for length of test, and no preference for cost. We repeated the same search for executive function. Our search resulted in 4 cognition instruments and 3 executive function instruments. The 4 cognition instruments included the mini mental status exam, the kettle test, the short orientation memory concentration test of cognitive impairment, and the executive function performance test. 3 of these 4 instruments also resulted from the executive function search. We first compared the clinical utility of the instruments. We eliminated the mini mental status exam and the OMC because they are both screening tools and may not provide the depth of information required to answer the primary questions of understanding the amount of assistance required to perform daily tasks and discrimination of current cognitive status. Additionally, the screening tools would not provide a method to measure change over time. So this narrows the list to the Kettle test and the executive function performance test. When comparing these measures for reliability, there is very little literature to compare. Study populations included are acute and chronic stroke. Given that acute stroke patients are likely experiencing spontaneous recovery and rapid change, the chronic patient population would be more similar to Lucille. However, sample characteristics of age and educational level should also be reviewed to understand the applicability to Lucille's case, since these are both factors that can contribute to executive function. Reliability is higher for the EFPT than the KT, and the reliability coefficient is above the 0.9 threshold for clinical utilization. This indicates that the EFPT may have better reliability for this clinical situation. The Kettle test has been tested in the elderly population for validity. It has an acceptable correlation with the MMSE, which is a cognitive impairment screen. The test has an adequate correlation of 0.59 with the clock drawing test, which is a test of visual, spatial, and praxis abilities, and may determine the presence of both attention and executive dysfunctions. This test has a poor correlation with the star cancellation test, which assesses unilateral visual neglect. This is an expected result since this is not the construct the KT attempts to measure. The population in the study had a mean age of 75 and was referred secondary to suspected cognitive deficits. The EFPT has been tested in acute and chronic stroke for validity. Reviewing the results from the validity test in the chronic population indicates an adequate correlation with the EFPT and all of the tests, both the digits forward and trails B, which had poor correlations. These results indicate the EFPT may assess executive function, but the correlations to similar measures were only adequate. In summary, the data indicates that the Kettle test demonstrated adequate validity in a similar elderly population, and the EFPT demonstrated adequate validity in a chronic stroke population, but it has not been tested in the elderly. One of the limitations to both of these instruments is that they can only be administered one time because a learning effect could occur during the test administration. This would adversely impact the test's ability to measure change from an intervention. Since 2 tests cannot be performed on one patient, the SEM and MDC have not been established. Floor and ceiling effects have also not been established for these measures. This case illustrates a situation that many of us encounter every day in the clinic. There isn't an ideal instrument to assess the patient or construct for our specific purposes. Even with the lack of evidence, measuring is better than not measuring at all. Review the goals of the instrument and the information it can provide and look for similarities between your patient and the sample of patients that were studied. If a test hasn't been assessed for test-retest reliability, it just means that we don't know how reliable the measure is in that situation. It doesn't mean that you can't use it for a follow-up test. However, it is critical that we understand the limitations of the instruments we select for clinical use. For Lucille, both the Kettle test and the EFPT would provide the answers to the questions put forward by the patient and her daughter. Because the Kettle test hasn't been tested for reliability in a similar population, the EFPT may be the preferred instrument for this particular case. Although the EFPT wasn't tested in the elderly population specifically, it was tested in a chronic stroke population that consisted of elderly individuals. If the EFPT is used multiple times to track change that resulted from treatment for Lucille, a learning effect could be considered a potential reason for changes seen. The measurement is one piece of the puzzle. Other standardized instruments administered, clinical observations, and reports from the data can help confirm whether improvements are actually being seen. These cases demonstrate test selection for individual patients and clinics. Typically, clinicians do not have time for this level of investigation for every instrument and every patient seen. We recommend selecting instruments based on the general population and treatment goals at your clinic. Understand the psychometrics, clinical utility, and the indices of change for each instrument so that you understand the implications of the instrument's limitations on each individual patient.
That brings us to the end of the webinar. We would like to review the objectives. Following the webinar, learners will be able to select valid and reliable instruments for specific clinical measurement situations for older adults in rehabilitation. Learners will be able to describe the common clinical sources of measurement error and understand what to do about them. Learners will be able to interpret measurements from one assessment, change across two or more assessments, and for prediction in rehabilitation for older adults. And learners will be able to discuss elements of validity and reliability relevant to clinical measurement in rehabilitation for older adults. For more information on the Retirement Research Foundation, we encourage you to visit their website at www.rrf.org. Thank you very much.